started, and hopefully people will be able to join as the session goes on. So I just want to welcome everyone to Project Echo Age Positively. For those of you whose first time it is coming here, welcome. And I just want to share with you that today's session is going to be on deprescribing. But before we go to that, if you are new here, you'll be able to find the material from the previous sessions and the recordings and slides on the iEcho platform. If you have any issues with that, then do give us a shout out and we'll be able to help you with that. So before we start the didactic session, I'm just going to hand over to Norman for any announcements.
Sorry, thank you. Thank you so much. For to those who have been with us for a while now, what I'm about to cover might be old music to you, but to those who are new, welcome. If you haven't already, we encourage you to change your Zoom ID, Zoom display name to your name, your area of expertise, and country, so we know where you're coming from. If you have any questions, please do use the chat box to drop all of your questions. We'll try our best to address those questions as we progress along in our session today. We also encourage you to turn on your video to ensure that our learning session is engaging as possible. If you're not speaking, please use the mute button. And as mentioned, the session will be recorded and all of the learning materials will be on the iEcho platform. In acknowledgement of the diversity of our participants, we acknowledge that English may not be everybody's primary language. So if you would require translation, there's a button down below with the letter CC. If you click on it, you can enable translated captions and you'll be able to look at the translation in real time as well. For clinicians from Malaysia, for you to redeem your CPD points, please fill in the CPD form that we'll share in the chat box, and we'll submit the submissions to MMA for your CPD points to be processed. Clinicians from Japan will send you a certificate of attendance, provided that you've completed the feedback form as well. Clinicians from Australia will also submit your name and place of practice to ASHM for your CPD points. That would be all for now.
Thanks, Norman. So, as we're heading into our didactic session, let me introduce Professor Shaun Lee. Shaun is a researcher and academic at Monash University Malaysia's School of Pharmacy. He's known for his work in pharmacy practice research and digital health innovations. His research focuses on improving medication safety, pharmaceutical care, and the implementation of digital health solutions in healthcare delivery. So today he'll be speaking to us on polypharmacy and deprescribing. So handing the session over to you, Shaun.
Okay, thanks, Pui Lee. Thank you for the introduction, and hello everyone. So it's my first time presenting in this very lively and very engaging audience. So let me just start off by saying thank you, and also just to declare I don't have any conflict of interest related to this presentation. So maybe I think I'm gonna start by just quickly speaking, and I think everybody here will be very familiar that aging population is really increasing every year, and we are in Malaysia, or at least in Southeast Asia, we are the epicenter of aging, because by 2050 we are expected to have more than half of the global population, and this is expected to even increase faster as due to economic and social advancement in many of these countries. And this is just a different cut, but we can see here that for many countries, especially countries like Malaysia and India, we are going to an old age dependency ratio as we go on by the year 2040. And so this is just another different cut, but already in 2020, we are already an aging nation. And this is expected to grow even larger as we go on for the next 20 to 30 years. Now, with medication use, I think that's really my interest is that as we start to get older, we did a survey. When you look at them, 81% of an older adult would be on at least one prescription or more, and 29% of them actually use five or more medications. And this is what we term as polypharmacy, or the use of five or more medications. And if you count or look into the use of herbal and supplementary medications, nearly 1 in 2 older adults actually use some form of supplementary products, be it fish oil, and things like vitamin C, ginkgo biloba, and all. And 42% also use at least one over-the-counter medications during their lifetime. Again, when you look at things differently, so when you look at people living with HIV, I think this is where it's even more stark contrast, is because polypharmacy and multimorbidities is expected to increase due to our longevity. And so these among all of them, I think NCDs are among the most common cause of increase in terms of the use of medication. So our three good friends, hypertension, hyperlipidemia, and diabetes, they would contribute to majority of patients who are taking more than 5 or more medications. And so this increasing trend of multimorbidity doesn't only affect older adults, but also affect older adults and people living with HIV. So this is data from the US where they showed that when in 2018, nearly 62% of older adults actually take 5 or more medications. And a lot of them are due to the use of medications, especially as I mentioned earlier, the cardiovascular medicines, drug used for the alimentary tract, but also blood-forming organs and nervous system. So what about Malaysia? And I think later on, I'll show some data from Malaysia, which I actually pull off from here. But when you look at when you have 5 or more medications, or you take 5 or more medications, it's sort of like a recipe for many of us to say that, you are going to have a potential for drug-drug interaction. So this is actually a study on the prevalence of drug-drug interactions in people in Switzerland, in particular looking at HIV cohort. And when we look at them, actually, quite a number of them actually have at least one or more drug-drug interactions. So about 29% of them actually have some form of drug-drug interactions when they actually looked at the HIV population. And this can be a source of issue for a lot of people who are treating patients living with HIV. So this is a study that I pulled out from Sharia. So when I look at it, Malaysia, even with people living with HIV, we are slowly catching up. So we found that around 4% of older adult Malaysians with HIV actually are 50 years and above. But among these older adults, they are actually taking a median of 5 medications, and 54% of them actually have polypharmacy. So basically, 1 in 2 older adults are actually having at least a issue with polypharmacy. And the most common drugs that they take are antihyperlipidemic, anti-diabetics, and the calcium channel blockers, as I mentioned earlier. All these are for hypertension, hyperlipidemia, and diabetes. And when you look at the impact of concurrent use, there is actually increasing in terms of the burden and the complexity of HR patients, because as you know, with patients with HIV, they have to take quite a number of medications. And if you imagine you pile up more and more medications of different regimens, different dosage forms, they actually cause quite a number of burdens. So this study actually shows you that there is actually increasing complexity of medications among geriatric older adults. And when we look at adults in particular, the decision is quite easy because, if you give a medication, the benefits definitely outweighs the risk, because for an adult, there's definitely benefit in terms of prevention, either for primary or secondary prevention. But this decision is not really that easy when you look into an older adult, age 50 or 60 and above, depending on what's the cutoff score, or even 65 and above, because a lot of them actually have multiple comorbidities, and because of that, they have increased risk of polypharmacy and increased risk of drug-drug interactions. Again, because of their older age, they have physiological changes, which can obviously impact the way how drugs are metabolized. And I believe later the case presentation will discuss one of these issues related to an older adult. So I think this is just a summary, but as we know, as we start to age, things change as we start to age. So I'm already 40, and then as I start to age, one of the things that actually I begin to notice is that you start to gain weight even though you eat the same amount of things. Your heart rates changes, the muscles change, but also your vision. And imagine that actually occurs in an older adult, even in males and females, where there are changes in terms of the amounts of fat, liver, kidney functions, and all these actually do affect how the drugs are being metabolized and being distributed in the body. And so this is just a showing that, when you actually look at how an older adult who are on two different antiretrovirals, they actually have a wider, in terms of the area under curve or the therapeutic index, are definitely changed compared to an older adult, between a young adult and older adult. And again, because of this, there is a need for probably some dosage adjustments in this bill. Again, I think one of the issue with a lot of prescribing in older adults is because our guidelines are really an issue. So if you follow the hypertension guidelines, you then probably an uncontrolled hypertension adult may need 3 or 4 medications. If he has diabetes, your guidelines would recommend the use of metformin. And if they're uncontrolled, add on a second agent and probably a third agent before you go on insulin. And then with a patient with a heart condition, you give them something for primary prevention. So these all add up and doesn't look at a patient in terms of holistically, because they just think if you follow prescription guidelines, they would add up and cause issue with polypharmacy. And again, I think these are just different ways we present the data, but with patients with polypharmacy, there are an increased risk of drug-drug interaction, as mentioned, but also an increased risk of hospitalization and also mortality. And we expect more prescribing errors, especially in older adults, because this data from the UK or Swiss cohort just shows you how the different people with polypharmacy have a prescribing error in terms of how drugs are given incorrectly, prescribing omission, inappropriate drug, or even some drug-drug interaction. So some of the main risk factor for inappropriate prescribing among all is females, drugs on CNF, but also individuals with renal impairment, and those are undergoing HIV treatment. And I think this is a really good platform for us to discuss about this, because when you look at them, inappropriate prescribing actually occurs in 1 in 3 older adults. And because of that, they require more hospitalization and also emergency visits. So eventually, I think I just made this cartoon up, but this can be how your patient would be with HIV and taking a medication. So they just feel like they're swimming or just sleeping with the pills every single day. And so the burden of aging in older adults in terms of polypharmacy and drug use can actually be improved. And one of the things that we have been looking at, or I've been researching quite a fair bit, is on this concept called deprescribing, which is basically the systematic process of identifying and discontinuing drugs in which there are potential harms, or even where the harms outweighs the benefits. And looking, of course, taking into consideration the patient's goal and level of functioning and life expectancy. And I think I'm I'm just going to share a little bit, is that when we look at deprescribing in general, there are fewer medication errors in older adults because we did a review and looking at that, there are fewer medication errors. There is improved medication adherence. So when we look at medication review directed deprescribing, they reduce the number of potentially inappropriate medicine by more than half, around 60%. And this can actually reduce the risk of healthcare associated costs as well. There are fewer falls and fractures among these older adults. So they could actually reduce the number of fallers by a quarter. They reduce the need for referral and acute services by about a quarter as well. But also they lead to better quality of life. And I think that's really the ultimate goal for everybody in this room, I guess, on this Zoom call, is that you want the best possible outcome for your patients. And one of the things that we really look into is the better quality of life. Now, when then do we consider or an individual is appropriate for deprescribing, or when can it be considered? So these are some of the obvious answers here, looking at indication, toxicity, lack of effectiveness, and inappropriateness. But again, one of the things I would like to highlight is that we did a survey and also looking into a review. One of the things that we found is that nearly 8 out of 10 older adults in general would deprescribe or have their medications reduced, again, if the doctor says they're willing. And when we zoom into older adults who are HIV positive or living with HIV, I think you can safely say that 1 in 3 actually think that feel that they are taking too much medications and they would like to have their medications deprescribed or reduced if possible. And so there are 2 strategies I would like to share with you on how we can actually reduce or deprescribe. One is obviously cutting, where we use a predefined medication list. It's very easy to perform. So these are your common and well-known PIM list from the Beers and start-stop, where there is already scientific evidence to show that they can actually be reduced, or a safer alternative can be recommended. The second alternative is really pruning back, where we actually think and sit down carefully, looking at patients specifically where there is a need for multidisciplinary performance, looking into their comorbidities and their frailty. The idea is to discontinue or inappropriate medications as much as possible. And so how we actually did it, so we actually ran 2 clinical trials looking at deprescribing in older adults. So one of the first things that we ever did in our study was actually to do a medication reconciliation. And you'll be surprised to know that, among older adults, basically 8 out of 10 never had their medications reviewed for the last 5 to 10 years. And so this is one of the first key steps we would recommend if you are interested or thinking of deprescribing, is to probably just speak to your friendly pharmacist in your ward or in your setting, just to have a medication reconciliation, just to take what we call a brown bag experiment, where we just we give them a brown bag, we ask them to check every single thing, their OTCs, their medications, but also importantly, any supplements that they're taking on. And then the second one is we conduct a periodic medication review. In this case, we recommend something to be done every year, assessing the appropriateness and safety of medication using tools, as I mentioned, to stop the Beers, and also something we've recently developed called the MELPIP 2. And this is where you can actually do medication prioritization, determining the critical medicines to focus on. So again, this is really a study I mentioned. One of the things that we actually started off when we thought of deprescribing is to develop a local tool, because in Malaysia, the Beers are really looking into the American medication list, and a lot of the medications are not really available in the American tool that are not useful here in Malaysia. So we developed this tool called MELPIP, and has been used in the geriatric pharmacy protocol. So there is an app here that we developed. So if you're interested, do scan the QR code. It's available at the website, but also available as an Android app where you can download it. And so Probably, I think some of you are maybe interested to do a deep prescribing. And then I think one of the first things that we actually always think about is that there are 10 main drug classes that you can consider. So these are the usual suspects, the first generation antihistamines, things like hydroxyzine or diphenhydramine, which are quite common in our setting. Tricyclic antidepressants, we don't use a lot of benzodiazepines, fortunately, but these are all something that you can consider. The atypical antipsychotics, the urological drugs, stimulant laxatives like Senna and bisoprolol. So these are quite commonly prescribed for older adults. The NSAIDs, digoxin, the long-acting sulfonylureas, and also some flu medications and antihistamines. And so I think from a lot of them, I think some of the questions that you want to ask when you actually start prescribing is that first question we typically ask you to consider is that are all these medications needed or are the dosages correct? So these are some of the common questions which we would, obviously do. But again, these are some very often overlooked in our daily practice. And is there something else that we can actually offer to the older adult? Are there, things like, after you have already talked about them, think about and get the patients involved in the decision where we look into their patients, asking them whether is there, what are their medications believed, but also medication being practiced because adherence is always an issue with older adults. And I believe that for many people, medications are only effective if they take them. And for many older adults, they sometimes tend to omit a lot of medications because they already know what are kind of side effects. And so I think that's where less burden of the disease, and that's where we want to try to reduce the number of medications. And so for people living with HIV, I think there are also suggestions or studies looking into deprescribing antiretrovirals, looking at, as I mentioned, doing a drug reconciliation and then looking at the patient's complexity. Is it an older adult living with 50 years or and above with some polypharmacy? And that's when ART experience patients living with HIV can be recommended with an optimal profiling of resistance training where they can actually be recommended a 2-drug regimen. So this has been actually done quite successfully. There are 2 clinical trials looking at 2-drug regimen. One's called a SALSA and one's called a Tango. I'm not going to say that I'm an expert in this, but I believe when I looked at this, they have actually shown that when you switch to a 2-drug regimen compared to a 3-drug regimen, they're non-inferior in terms of all the outcomes that they're looking at. But they also have some associated benefits in terms of metabolic effect, in terms of having better control of total cholesterol and also HDL and LDL. And this may also be something that you may want to consider because, as I mentioned, a lot of people, older adults living with HIV, they actually have an issue with metabolic disorders and NCDs. And so these are some of the key takeaways is that, they may actually, favor some of these, while there are some changes in lipid do favor not changing it, but there are some good metabolic parameters among this group. And so I think that's where you may want to consider. Because I think at the end of the day, what we don't want is to have this conversation where, as a doctor, you'll be asking your patient, when you prescribe more medications, you're just asking them in a way, what side effects do you want today, in a way. I think that's about our 20-minute sharing today.
That's perfect timing, Shaun. Thank you. I'm going to open up the next 10 minutes for some discussion and questions. So feel free to put your questions in the chat box. If you want, you can raise your hand, unmute yourself, and ask a question. Just wondering whether anyone has any questions yet. If not, I can start us off. Yeah, so I think what I found really interesting about deprescribing, well, firstly was hearing about the beers, the start and stop, and the Malpip. I don't know if that's what you call it, Malpip.
Yeah.
I think they're very interesting tools. I'm not sure how familiar everyone is with them, so I was wondering if you could just maybe explain a little bit about what those tools are. Um, and also my kind of second follow-up question to that would be, for those of us who may not have, a dedicated pharmacist for our HIV patients or people living with HIV, um, what can some of us start doing? So whether it's nurses or family medicine or ID physicians.
Yeah, thanks. Thanks, Willie. So I think for the first question about the tools, I think the peers, the stop, and also the Meltip that we developed, these are tools that are used to guide or to identify potentially inappropriate medications. So these are medications where probably they will just we use it to flag, probably, as I mentioned, antihistamines, the first generation as antihistamines, where if you look into our tool and you type all the different medications in there, they will be able to help you identify if there's a risk of drug-drug interactions, a risk of an older adult experiencing side effect. Now, a lot of these tools, one thing about these tools is that they are not a they are only used as a guide. They are not like a Bible or something that you must do. So a lot of it also still relies a lot on the skills of the doctors and attending physicians that are treating these patients. Uh, to your second question, Puili, I think with people living with HIV, I think there are some sensitivities towards sharing of information, I guess, with a lot of these individuals. So one of the things I would strongly recommend is that you work with your nurses or even with the geriatricians, just first conducting a medication review, asking your patients just to bring back their medications that they have. So what I term the brown bag experiment. So you just give them a bag. It can be any bag, and just ask them to throw every single medications and supplements that they have. And sometimes you'll be surprised. So one of the I remember this older adult that we did a review. She came with 3 ice cream boxes of medications. Uh she had tons of calcium supplements, and she had never taken them. There was 1.5 ice cream boxes of calcium supplements in there. Uh, there were like 15 or 20 different medications in that 3 ice cream boxes. So I think that's really the first step. Just getting to know your patients, what they are on, because they are also on a lot of different supplements, and with the direct selling, they have a lot of different things that God knows what they are on. So I think that's the first thing I would like you to do. I have a second question. Would changing lifestyle be an option to reduce polyprescription? I think that's quite an interesting question. I think that could again be a good strategy, especially for those who are having NCD. So, for instance, diabetes, hypertension. We know that lifestyle does play a large role in a lot of these controls of these metabolic diseases. But I don't know, and depending on how severe and how bad these metabolic diseases are, I think, but that's definitely a first option, I guess. So the third one is what are suggested timelines for medication reconciliation, periodic medication review, and medication prioritization? Okay. So I would recommend every one of your patients have a medication reconciliation at least once in their lifetime. And once they have done that, you do a periodic medication review every 1 year or every 2 years. We have been doing this study in 3 states, in Perak, I think in Perak, Penang, and Perlis. So looking into older adults medications, looking at deprescribing, and very interestingly, after 6 months, all the medications that we initially deprescribed were back on the list. So I don't recommend doing it every 6 months because, again, it's very, very tedious and taxing. So on average, a proper medication reconciliation takes about an hour to an hour and a half. Medication review may take half an hour of your pharmacist's time, and that's when and medication prioritization is when you have a multidisciplinary team discussing about this case study. So this ideally should be done when you have a, a group of you, just as similar to how you do a case discussion.
Yeah, I mean, I think, just continuing on with what you were saying, I think one of the things that we struggle with, for example, is, if we have a patient who sees us and then sees renal because their kidney function is getting worse and they're managing the hypertension, and then they also see another family physician in the community that's managing their diabetes, right? So then you end up getting prescriptions from different places. And I find that part very challenging to reconcile because I would have to get together these various people to manage the medication. And I think the additional challenge is sometimes when they go to another clinic, they don't often mention about having HIV. So that's the additional puzzle piece that's missing from that as well.
Yes, I agree. I think pretty, and I think one of the things, even with older adults, is that challenging. So I think for your cases, it will be a lot more challenging. So one of the things that we are now starting to implement is that we actually will give every single one of our older adults, which we did de-prescribe, a sort of a discharge summary,
Mm.
and we ask them to bring it to every single doctor that they go into so that they actually have a history and said, look, because I think there's a tendency for them to continue on their medication. Yeah.
Yeah.
So
Yeah.
I think that could be a nice tool for you to use as well, just having a discharge summary where you mentioned that these are the medications that they're on. We've removed this really because of A, B, C, D, E, and we did a medication review and put in, and we mentioned and we put in a number of the pharmacists or the hospital in there so that they can contact if they have any queries. And I guess the challenge or the worry is really from the primary care, because when they are in primary care, they tend to see a lot of prescriptions from consultants and specialists, and they would never de-prescribe it, even though they have very good reasons to do that.
Mhm. Okay. I don't know. I'm wondering whether Ken has anything to add to that um, from a primary care perspective, or what your experience is.
I think blatantly obvious, then I will write back to the consultant and say this contradicts or
Sorry, Ken, I think you're cutting in and out. Either that or it's me.
maybe I'm talking too fast.
I
In
think the
my
sound's
practice,
coming out.
a lot of patients that are 60 plus, HIV positive, who are on 5 or more medications. I can think of a hand, and I would so love to de-prescribe, but I look at off. And so it is a challenge, especially in primary care when we don't have that easy or easier access to a pharmacist. We have a program in Australia where we to do a medication review and to come back with recommendations, but it's so involved. You have to send referrals to the pharmacy. Pharmacist has to get to the person's home. Then they come back with a report and you look at it and you go, you're not really telling me a whole lot of stuff. So it's sometimes difficult to implement. I'm actually trying to work with one of our local pharmacies to put a pharmacist in the general practice. It's a project. Perth, that is a HIV general practice that has a pharmacist patients to.
Yeah. Ken, I'm really sorry. I think we can't hear you. The connection might not be very good.
That
Um,
issue about communication is so vital, because you take something off and they go back and see them and they put it back on. So I find that that's a problem too.
Okay, thank you. I think, Shaun, there are just two more questions. I think we'll just take those two
Yep.
questions and then we'll round up.
Thank you. Sure. So I think the question is, how many drugs best to deprescribe at one time? I guess from our own experience, the best is if you do a maximum of 2 drugs to deprescribe at one time, because you also want to monitor to make sure that the older adult or any of their if you deprescribe antihistamine or any painkillers that are not needed, or even a proton pump inhibitor, you want to make sure that they are okay. And so I think one or two at a time is typically what we recommend. And then you slowly taper off as time goes. One of the other ways that we can also reduce or deprescribe is also to use single pill combinations. So these are quite common nowadays with the SPCs, single pill combinations. You can have 3 or 4 medications in one pill, and that also is a form of deprescribing. It's very, very effective. How can we encourage or initiate patients to raise questions on polypharmacy during doctor's consultation? I guess probably for us, one of the things that we actually ask the patient is that would you like to have your medications deprescribed? We notice that you have 5 or more medications. Would you be happy to have fewer medications? And I think, as I mentioned, 8 out of 10 actually more than happy to take fewer and fewer medications. So I think that's probably a first question you want to ask your patients, whether have they any issues with taking the medication, and if yes, would they like to have fewer medications? And I believe most people would say yes to it.
I can't imagine anyone saying no.
There are.
All right. Okay. Thank you so much, Shaun. I think there's still maybe a couple of questions coming in. There's a question from Yifan, but if you don't mind, would you be able to respond to him in the chat so that we
Yep,
can
sure.
move on to our next session?
I will do that.
Thank you so much. And so now we're going to move on to the case discussion. And today's case will be presented by our hub member, Priti Raghavan, who's our beloved pharmacist. So she works in the National ID Center in Malaysia, and she's a credentialed retroviral disease pharmacist by the Ministry of Health Malaysia, and has been running the medication therapy adherence clinic for retroviral disease for more than 10 years. So Priti, over to you.
Good evening, everyone, and thank you, Dr. Pui, for the kind introduction. Today I will jump in straight on with our case on polypharmacy. So meet patient MAM. He's 65 years old, gender identified as male, and his sexual orientation is heterosexual. His ethnicity is Malay, and there's a key population of commercial sex worker. The patient's presenting complaint was high fall risk that is related to instability and sensory factors that are non-modifiable at moment with his multimorbidity. He also has osteoporosis, fragility, fracture that is complicated with metabolic disorders, whereby he has underlying chronic kidney disease with stage 3. He has already accepted a renal replacement therapy, but however, he's still not on RRT yet. And he's also experiencing deconditioning with frailty secondary to the above, and multimorbidity with poorly controlled vascular targets. His mobility, he's limited to his home. He always comes in wheelchair. He's able to ambulate, but with assistance for short distance. He mostly requires a walking stick for support and is able to stand, but he also needs some assistance to stand up. He often relies on furniture to push himself up and requires someone beside him for added stability. Once standing, he can ambulate within the house using a walking frame. In terms of his vision and hearing, his right eye vision is limited and blur, and his left eye has been eviscerated so that he's completely blind on the left eye. There's no hearing impairment. For cognition, his scores indicates mild cognitive impairment. He's able to recall the three items, suggesting intact short-term memory. However, there are occasional short-term memory loss in terms of misplacing objects, forgetting recent events, and repetition. He is able to sleep overnight, no hallucinations. There are mood changes on and off, depression, anxiety, and irritability. Aberrant motor behavior, but nothing significant that require neurological investigation. Activities of daily life and instrumental ADLs and basic ADLs. For his basic ADL, he is independent in terms of eating, toileting, ambulating within the house, but his mobility is once again more limited to the home, and he spends most of his time in bed, so which may contribute to physical deconditioning over time. ADL, he manages his personal hygiene and self-care independently. However, for instrumental ADL, his vision impairment restricts his participation. However, he listens to the radio to stay updated. For the modified Bartel index, he scored a moderate level of independence in terms of his activities of daily living. And physical activity, once again, is reduced due to his vision impairment and reduced mobility. However, he remains independent in his essential movements like walking to the toilet and dining area. For patient's social factors, he is divorced. He is divorced and blessed with 5 children. Heterosexual, but there were no other further details obtained. No substance abuse, no substance use. He lives with his stepbrother in a double-story home. He was previously a banker. The patient receives excellent support from his stepbrother, who is the main carer for the patient. He has his 5 sons who live in KL, and they have been asking him to live with them, but he has refused up till now. The carer also has expressed that he faces many repeated challenges with multiple appointments, with many different clinic appointments, and also managing the high pill burden. As for his medical and surgical history, he has a repeated admission for hypertensive urgency with underlying resistant hypertension. He was treated for NSTEMI and started on ACS treatment in 2021. And the last echo findings showed EF of 40%. He also has chronic kidney disease with stage 3A. His latest ultrasound showed bilateral renal parenchymal disease, as well as, but there was no evidence of renal artery stenosis. He also has type 2 diabetes. He was diagnosed with HIV in 2018. He also was admitted for COVID infection category 4 in January 2022. The patient has ocular issues. As I mentioned before, his right eye has limited vision due to pseudophakia, and his left eye has been eviscerated. And he had 2 episodes of fall, one in January 2023 where he missed a step and fell on the staircase, and August 2023 during this admission he missed a step in the kitchen. So his recent bloods in February 2025, those highlighted are the abnormal results. He had a HbA1c of 5, fasting blood glucose of 4.4, His latest creatinine was 224 with a creatinine clearance of 27. All other renal parameters were within the normal limit. His liver function was within normal limits as well. His lipid profile, only his LDL was slightly elevated. And for his full blood count, his HB is 9.3. He has not been vaccinated for HPV, Hep B, COVID, or pneumococcal. And he has mentioned that during vaccination, especially for COVID, he was deemed unfit and hence did not get his vaccination. Hep C and B non-reactive. His latest weight is 66 kg with no edema, osteopenia, and his calculated clinical frailty scale score was 6. The latest CD4 count was in May 2024, which was 402, and September 2024, his viral load showed undetectable levels. I would also like to mention here that his viral load has been undetected since 2018. So I've also put up his renal profile. Prior to heart, his creatinine was 109. As you can see, the trend, it has been in increasing trend with the latest 224. And also his latest bloods showed significant proteinuria. So he has 15 medications on board currently for his cardiprine, for his secondary prevention of CVS, statins. He's on glycoside for type 2 diabetes. He is on 5 antihypertensive for his high blood pressure or resistant hypertension, calcium carbonate, calcitriol, zinc copper for anemia, and he is on abacavir, efavirenz, and lamivudine for his retroviral disease. He was initiated on abacavir, lamivudine, and efavirenz since diagnosed in January 2018. And his heart was initiated on the 12th of March. So the patient has had regular medication adherence assessment with the pharmacist, and we have rated the patient to have inadequate adherence. So his right eye has limited vision, but he prefers to take his medications on his own. He is a very well-spoken but a very assertive character. Medications are prepared by his stepbrother, who's the caretaker every day in the mornings and evenings. But however, upon counseling the patient, we found that the patient claims that he does not have any medications to be taken thrice a day, but he actually has been prescribed with prazosin 3 times a day. Last visit, we have also advised the patient to use pill box and, if possible, colored pill box to differentiate between morning, afternoon, and night medications, especially with his limited vision. There have also been occasions when he does not take his antihypertensive, when he has some arguments or conflicts with his family or sons. So there is definitely an issue of non-compliance with this patient. There is no swallowing issue with the patient. However, patient has multiple TCAs with ID clinic, CKD clinic, ortho, optal, and fall clinics. He does self-monitoring of BP at home, which is ranging from 170 to 100. He claims there is no traditional medication, supplements, or painkiller intake. In terms of financial support, the patient is a former banker, so he is financially stable with no financial constraints. He receives strong support from his children and brother, although there are occasions where they have misunderstandings. He has informed his doctors that he is able to personally purchase certain controlled medications if required, if it is not available in the government setting. However, at the moment, all his medications are prescribed from the hospital and are provided to him free of charge. So moving on to some of the points that I would like to discuss today. So my first question is, how can deprescribing be safely implemented and which medication should be prioritized based on safety and efficacy in patients with multiple conditions. So here I've used the Beers and the stop-start criteria tool, and there are 3 drugs that listed and classified as fall risk increasing drugs. One of it is prazosin, and it has been deemed as inappropriate in recurrent falls, especially as this patient has encountered 2 falls due to risk of orthostatic hypotension. Spironolactone, even Stop and Beers has recommended to avoid spironolactone in creatinine clearance of less than 30 because of the risk of hyperkalemia. Our patient's creatinine clearance is 27 and his potassium is still within the lower limits. And so here, can we safely deprescribe prazosin considering the risk of rebound hypertension and also the deprescribing of spironolactone, given its benefit in heart failure and his reduced ejection fraction? The second question is how can we optimize or simplify his hypertension management? So as we have seen previously, he's currently on 5 different classes of antihypertensive, and he also has adherence issues whereby he sometimes skips his antihypertensive due to conflict or confusion, and also has vision impairment. Here, I would like to get some feedback. These are my recommendations to use a fixed dose combination to reduce his pill burden. That is to convert perindopril and felodipine with Xforge, which is amlodipine and valsartan, which is shown to have beneficial effects in heart failure as well as in hypertension. To switch metoprolol BD dosing to once daily dosing of bisoprolol, and also to stop prazosin and start a low dose of terazosin, and ensure adherence, monitor BP, preferably caretaker to dot the patients, and to continue spironolactone and furosemide with close monitoring of patients' potassium levels. Now, moving on to my third issue here is, or third discussion here is patient's fasting glucose, which is 4.4 and a HbA1c of 5%. So this may indicate an over-controlled diabetes, which may increase the risk of hypoglycemia. So many of the guidelines have suggested for older adults the HbA1c to be between 7.5 to 8%. And Beers have also classified sulfonylureas glycoside to be used in caution in patients with CKD and fall risk patients due to the risk of hypoglycemia. So the question here is, can we safely deprescribe glycoside and start on other safer alternatives? And as I'm reading the case notes, the doctor has a future plan to start the patient on tablet dapagliflozin. And from my reading, I have found that dapagliflozin has FDA warnings regarding the increased risk of volume depletion, genital yeast infection, and acute kidney injury, especially in elderly. And I would like to find out if it's an appropriate choice for this patient. However, I would I could be wrong, but I would like to recommend that we switch to a DPP inhibitor, which is linagliptin, which doesn't require any renal adjustment. And it's also once daily dosing, has a neutral effect on weight, and it has been shown to have minimal risk of hypoglycemia, especially in elderly. And I would recommend to monitor the fasting blood glucose as well as post-meal readings for 1 to 2 weeks, and aim for an FPG of 6 to 8 and a HbA1c between 7 to 8%. Now, my next discussion is on efavirenz, whereby we all know that it has neuropsychological effects such as impaired balance or slowed reaction times that could contribute to fall risk. So I'm wondering if efavirenz is still appropriate for this patient given his mild cognitive impairment or FR variants could probably worsen his cognitive impairment and increase his risk of fall. And would switching to a dolutegravir based or a dual therapy of DTG regime be beneficial for this patient? And there are also drug-drug interactions here. So efavirenz is a cytochrome P3A4 inducer, whereby it reduces the atorvastatin levels, and hence you can see that the patient is on a high dose of atorvastatin, 60 milligram. Now, the target based on guidelines for elderly is an LDL of less than 2, and the patient's LDL is almost 2.5, and he has a creatinine clearance of 27. So here I would again recommend to switch to dolutegravir and consider a lower dose of atorvastatin, because higher dose may predispose patients to increased creatinine kinase, muscle pains, and uh, also check for muscle pains, weakness that may contribute to fall, as well as patient's liver enzymes. And if the patient is switched to dolutegravir, it's important to counsel the patient for drug interactions, especially with calcium carbonate and zinc copper, which the patient is on currently. And yeah, so yeah, that's about my case presentation today.
Thank you, Pretty. If you can leave your slides on, just because there
Yeah.
are so many things to discuss.
Yes.
But I just want to add that I think that your case, just illustrates so beautifully why we are having this platform to have a discussion on HIV and aging, because all of these are such common things that we are starting to see in our clinics nowadays,
Yeah.
and also, I guess, in primary care. So, I think Kajal is on the call, but I think she's just kind of catching up with things. But to your first point of discussion, I think one of the things that I learned from our geriatric colleagues, it's always with the uncontrolled hypertension, whether it's really uncontrolled or it's just that he's not taking his antihypertensives, right? Because you've highlighted that he's got this visual impairment,
Correct.
and we don't even know if he's taking it, because prazosin, as you've highlighted, is 3 times a day, and he said he's only
Yeah.
taking it twice a day. So actually, maybe he's not taking his drugs because
True.
there's just too many, and that's why he's getting the complications of hypertension, which subsequently then has led to the worsening of his renal function and proteinuria as
Yeah.
well. So personally, for me, looking at this case, I definitely think that there is a role to try to look at his like consolidate his antihypertensives. For a similar case we had, I remember Kajal had also suggested to us, it might be worth just like admitting them for like a day or two, to adjust their antihypertensives safely, and you can actually
Okay.
monitor the blood pressure from the
Yes.
medications you're giving. But obviously being mindful that we're only doing this for, a couple of days and nothing longer, because obviously there's the risk of hospital-acquired infections, which we do not want to give to our patients.
Yeah.
Yeah.
So actually, I we in my first question, we did not really de-prescribe anything. I think I have just simplified it by starting a fixed dose combination to reduce the pill burden here.
Mhm. Kajal, you wanted to say something?
Hi, yes, thank you, Preely. Thank you, Preeti, for such an interesting case. I just wanted to jump on what Preely was saying, that number one, yes, we definitely don't like prazosin in older persons, really, because they tend to get lots of side effects, and they're very smart. The moment they get side effect from the very first few doses, they will then continue to not take it at all. Number two, it might be worthwhile to actually get the person to do a 24-hour ambulatory BP monitoring, because that gives you a true picture on what the BP control is at home. Because what happens often is office blood pressures are really not accurate, like when they come to the clinic and you check the blood pressure. And sometimes when they check, say, at one standard time, say they get up and they want to check their blood pressure, and then it happens to be high, then it goes into a vicious cycle. Oh my God, my pressure is high. I need to take my medications. They'll check again, the pressure is high. And they're going to report this to the doctors. So I would definitely suggest when we are trying to titrate medications, number one, it's good to do a 24-hour ambulatory. Number two, the lesser is better. Number three, even a simple sitting, lying, sitting, standing BP that can be done in any clinic is very, very helpful, because the moment you can document a postural drop, then you know your target BP will need to be dropped. Meaning what I'm trying to say is, so say your patient comes in with a BP of 160/80 and you think, it's a bit high. I wish it's a bit lower for his, because he already has got proteinuric CKD. You want it to be a bit lower. But if you document a postural drop, you get him to stand up 3 minutes and you repeat the blood pressure, and now it drops to 120/80, for example, then you know he has got significant postural drop, and you shouldn't be increasing the antihypertensives anymore. In fact, you should be cutting down. And for this patient, I agree with the switching the metoprolol, because then you give him a OD dosing. But I'm not even sure why he was on an alpha blocker in the very first place, given that he already has got multiple comorbids. Perindopril, felodipine, I was seeing the creatinine creeping up, whether or not the ACE inhibitor needs to be stopped. Thirdly, he's also on furosemide. If you follow guidelines, if the patients are not clinically overloaded, we no longer need to give them furosemide on a regular basis. You just need to optimize their pillars. He's already on ARB, which is very good. He's on a beta blocker, which is very good. He's on a spironolactone, which is very good. So actually, if he's clinically not overloaded, the fusi can definitely be stopped, because pedal swelling, just saying, pedal swelling is really not equivalent to overload. Sometimes it's basically just proteinuric, low albumin, unless they're symptomatic, because then we can optimize their heart failure and CKD medications instead of just pushing. Because you rightly said, you're going to put them into hypovolemia by giving them spironolactone, furosemide, which will then tip them into, probably giddiness, postural drops, and precipitate more falls.
Thank you, Dr. Kejal.
Thank you.
Thanks, Kajal. Yeah, so what was the next point for discussion? Okay. About the sugar control.
Yeah.
Yeah, I mean, I think the HbA1c, firstly, with him being anemic, makes it really difficult to interpret, because then it might actually be even, it might be above that as well. And I think nowadays we have continuous glucose monitoring that's available. And I think also some pharmacies are offering that temporarily. So continuous glucose monitoring may be helpful to see what his glucose control is like throughout the day in order to optimize his OHAs.
Okay.
I think personally for me, I think a lot more physicians are going towards the SGLT2 inhibitors because it's cardioprotective and it also slows down the progression of deterioration of the renal function, which is probably why I think the doctors were heading towards that. I mean, I think in terms of genital yeast infections and volume depletion, this is something that we typically risk assess with each individual and counsel them to see if they are the right candidate for this for dapagliflozin before giving it. Whether I would give, I mean, switching, I don't think I have any issues with switching gliclazide to linagliptin, especially if you're worried about hypoglycemia. But I don't see a huge contraindication to giving dapagliflozin. But, Kajal, please correct me if I'm wrong. In the geriatric population, maybe it's slightly different. But I think with where his renal function is going, it might be necessary, especially if his cardiac function is not great as well. Okay. Next issue. Okay, Giles, do you want to say something?
Puli, and Puli Preeti, I totally agree with you. I don't think there's any contraindication in giving SGLT given the benefits, but I would be a bit more concerned making sure that he knows on the right ways when he's taking these medications, given his poor vision, whether or not hygiene can be maintained. Because if he has got at any point any issues with LUTs or prosthetic symptoms, which can render him to be a bit more at higher risk of infections, then I don't think he's diapers dependent, is he? He seems to be BADL independent. Does he use diapers?
Yes. No, he doesn't use diapers.
Okay, so
Yeah.
then I guess we are okay. But for those patients who are on diapers, I mean,
Okay.
it's not in the booklet to say that you don't use, but we have seen enough of older, frail persons who are on diapers who come in with really bad urosepsis because of this SGLT2. So I
Okay.
guess for him, it's not wrong switching him, but he has got so many medications that can render him to be hypovolemic.
Okay.
SGLT2, furosemide, spironolactone. So it has to be really cautiously, going slow with the dosing rather than just a hit on all the medications.
So would linagliptin be a better choice instead?
I would choose Lina, definitely, rather
Okay.
than Dapa.
Okay, thank you, Dr.
He has got
Tina.
all the other medications that can help him to optimize his heart failure. And in terms of his sugar, I think if we can do a continuous sugar monitoring, even just for a day, just for us
Okay.
to understand where is it going up and if he's actually getting some relative hypos in between, because sometimes it's not truly hypo, but it's relative hypo, so we don't
Okay.
know. So until and unless we really know the trend of the sugars, it's very difficult to just keep up titrating medications plainly due to the HbA1c, because of
Okay.
CKD and all that may not be as accurate.
Okay.
Mm.
Thank you, doctor.
Yeah. Yeah, and I think especially if cost is not an issue for him, then
Yes.
CGM would be the safest way. Continuous glucose monitoring would be the safest way to do this. But yeah, before I go on to point four, for any of the hub members, if you want to jump in, please feel free to just like unmute yourselves and just and discuss. I just can't see because I'm like staring at the issue on the slide.
Really?
But yeah,
Hi, Pretty. Chen Hong
yes,
here.
Ching Hong, yeah.
Hey, hi. I want to add on something about the sugar control in this patient. So I totally agree with you because patient's anemic, so the A1C may not be
Accurate.
very accurate. Yeah. But we also take note that patient is on beta blocker at the same time. So I think continuous glucose monitoring for a period of time is definitely a good idea because we want patient to go on his regular diet and then monitor whether there's any hypo episode. Because of beta blocker, he may not demonstrate those typical hypoglycemic symptoms. So which actually worries us a bit more. With regard to SGLT2, if it's me, I've seen him in my clinic, I will probably still want to start give it a trial, but with very detailed education on how to prevent all this genital infection, prevent dehydration, and also give him 6 days a while. Especially now it's during fasting month. So sometimes I guess DAPA at a very low dose probably may not have much issue, but if a person with DAPA with some other OHGAs, right, we may need to adjust the dose a little bit. So this is some fasting month advice that we should think about. Yeah, thank you.
Thank you. Yeah. So with regards to his efavirenz, I think definitely without a doubt this man needs to be changed to a dual drug regimen. So drug regimen involves giving lamivudine and dolutegravir. I think he's currently on abacavir, lamivudine, and efavirenz, if that's right. Yeah, and I know in the past there was some evidence of people experiencing more myocardial infarctions with abacavir. That's from a DAD study in the past. But I think more and more trials and meta-analysis are finding that that may not necessarily be true. But either ways, I think that switching him off the efavirenz, especially with the recurrent falls, with the mood changes, switching that to dolutegravir would definitely be beneficial. And dual drug therapy obviously reduces that burden as well, the pill burden as well for him. Because I think lamivudine, he'll be on a very reduced dose of probably like 100 And that's probably a tablet, depending on what doses you have. And dolutegravir will be 1 tablet. So that reduces your pill burden as well.
Yes.
Yeah, and as you mentioned, with the cognition. But yeah, as you were saying about the drug-drug interactions, dolutegravir is definitely a better, more lipid-friendly drug for people living with HIV, and there's less interactions with atorvastatin. There's no interaction actually with atorvastatin for dolutegravir. So that might also, so the dolutegravir will likely help with the lipid profile and reduce it, and also give the ability for atorvastatin to function probably at a lower dose. So he'll probably get better lipid control that way.
Yeah. As I would also like to ask, what are the strategies that can be employed to overcome polydoctor and polypharmacy in patients seeing multiple specialists?
So maybe I can share what we are trying to do. So we have tried to start this multidisciplinary team meeting where we get the specialties that we predominantly see to come together to discuss the cases that really need them. So for this case, if you already have a cardiologist that's seeing this patient, and endocrinologist, so on and so forth, I would bring them all together, sit them down and discuss the case to see what medications you can take off. Yeah.
Okay, thank you, Doctor.
Yeah. All right. Does anyone else want to add anything? No? I think Ken's saying, is there a combination of dolutegravir, rilpivirine in Malaysia? I don't think so. No. And Shaun, was there anything you wanted to add following this case?
No, I think you've covered most of, not all of it already. Yeah. But I think, yeah, so just to add to Pui, I think we've just been discussing, so it's not an advertisement, but Think Caring actually does offer CGM. I think it's 220 for 2 weeks that machine cost, that test. So if the patient can afford it, it's not much. And they offer it for 220 for 2 weeks. So you get CGM. That, yeah.
Okay. All right. Any of the participants want to ask anything? Then I guess if there's no further questions or discussions or issues to bring up, then thank you so much, Priti, for sharing this case. I just think that it's such an impactful case.
Thank you, Doctor.
Thank you so much. And maybe I'll hand over to Norman for any kind of final announcements before we round up.
Yeah, thank you so much. Sorry for the delay. I wasn't sure if I was muted or not. Anyway, such a great session. We would love to hear your feedback about the session. I've shared the link in the chat box. But if it's not accessible to you, you can also scan this QR code over here. It will link you up to the form that is on iEcho, and you'll need to sign in into your iEcho account to provide the feedback. And once you've submitted the feedback, the system should send you the certificate of participation, and it will only be issued once the feedback form is completed. Our next session that is happening next month, April 9th, at the same time, will be on pain management. If you were accessing the call today and it just so happened that you're seeing management of pain, we have no idea why there was a switch between the titles. But this week as you know, is polypharmacy, and next week will be on pain management. So stay tuned for the next session. It's going to be a bit different. from how we typically do our session. So do join in, and we'll see what we can learn from pain management. I don't think there's anything else apart from case presenters. We are still looking for case presenters. There are still a few more sessions to go, and that we would like to open this opportunity for you to present a case, or if there's a case that you find difficult to manage in your own practice, we encourage you to share with us, and we'll help each other and support each other, and ultimately we hope that the case management will be improved as well. Yeah, so that would be all for me.
Thanks so much, Norman. And thank you everyone for coming for today's session. It's fasting month here as well, and I know everyone, for those who are fasting, you'll need to break fast. So thank you so much for spending your evening with us. And we'll just draw it to a close. Good evening, everyone.